This
Students, yes or
conference
no?
will now be recorded.
Uh,
Yes, sir.
this is the 8th semester student. So could you tell me now how many? 97. 97 have come. So could you ask some more people, at least 120? That is the right number to start. Because, in fact, I want to take this class tomorrow or day after to my postgraduate students also. Just now I was coming along, I asked you questions related to this particular topic, which is a very, very common topic, basic life support and advanced life support. I asked some of the very, very senior postgraduate anesthesiology students. Surprisingly, they were not able to tell me very correctly. So I'm going to take a class for them also. And this is something, uh, why Balkrishna has left, may I know? Please, Balkrishna, please don't leave the class. I'll be offended. Yes, I'll be offended. This is something which is very, very essential. Very, very essential. Balkrishna, would you like to join back? Please don't leave the class. I would request you to hang around for the next 30 to 40 minutes. I'll finish the class. I assure you. And what I'm going to speak is something very, very essential. As a doctor, you will always thank me for what I have spoken to you. So that is it. So, are you there? Yes. So now I'm going to tell today about ACLS with Advanced Cardiac Life Support. My name is, as I said, Dr. Colonel Pindiala Pradeep. I'm professor of anesthesiology. In fact, one of the assistant professor was supposed to have taken the class, but today he has left the institution as an emergency and he has taken a job somewhere else. So I've been requested to take this class. So this I consider, I reiterate, I'm sorry I'm reiterating repeatedly, just to give the importance, the weightage to the class. There can't be anything, assure you, there can't be anything more than this, which could be of any use to you as a doctor. So why I'm saying you are going to become a demigod, after knowing the basics of this. On the website you're doing? Huh? 115 have come, and that's a good number. So as I said, I would like to start it when the 220. So 115 have arrived, good number. So by the time I continue, I'm sure more numbers will. I can start here. You can tell you. Full is a full picture, correct? Next slide here. ठीक है. Got it. ठीक है. Please be seated somewhere else. So anything wrong. So, as I mentioned, Advanced Cardiac Life Support, ACLS, to provide theoretical knowledge and skills. Not only that, what I'm going to show you absolutely practical. You'll become master in resuscitating any person anywhere. Anywhere means anywhere, underscore. You are going to give a life to a dead person, I can assure. I have done countless resuscitation successful. Most of them I have done inside the hospital. They say the resuscitation rates are very low. I would disagree because majority of cases which have resuscitated, try to resuscitate, they all survive. Majority of them. So why I'm saying that if you do correctly, there is every possibility of resuscitating somebody, and either an adult or a pregnant lady or a neonate, just newborn child, successfully, provided you know what is to be done. That is very important, rather than just uh, 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 having the great desire to save somebody but not knowing theoretically what is to be done. At the same time, practically what is to be done. So I'll tell you about standard approach to CPR in an adult. It's a multidisciplinary nature of course, encourages a teamwork. If there is a teamwork, especially in ICU or MI room or as a casualty, there is nothing like you can definitely save a person, provided everybody is doing correctly in a teamwork coordination. This is an opportunity to gain experience as a cardiac arrest team members and team leaders. Today, I'm going to show something as a part of lecture, skill station, cardiac arrest simulation training also in a diagrammatic way. And I'll tell you about the latest guideline. Let me tell you a very interesting thing. American Heart Association has started some time back. I'll tell you exactly, somewhere in 1965 or 1966. So their job is to formulate, new guidelines every 5 years. So what I'm going to show, majority of the guidelines pertains to 2010. Now you will definitely ask me, sir, now it is 2020. Why do you want to show the guidelines for 2010? Incidentally, unless you know the basics of these 2010 guidelines, you won't understand 2015 as well as 2020. Surprisingly, 2020, American Heart Association could not give the latest guidelines, obviously for sudden arrival of COVID. So they have given one interim guideline how to resuscitate a patient when the pandemic is around. That's the beauty. I assure you that this pandemic is definitely going to leave us. So we'll go back to the old standard way of doing resuscitation. So you must know what is the old standard method of doing the resuscitation. At the same time, I'll tell you how to save yourself and the patient even in this pandemic, despite all the fears of exposure yourself to the COVID-19. So, as you see, history says the Bible mentioned that the first mouth-to-mouth breathing was done by God that put life into a statue of clay, the first man to the land. This is obviously earth. And the Lord God formed man out of the dust of the ground and breathed into his nostril the breath of life. From Bible, Genesis 2. Well, I'm a staunch Hindu. I'm not a Christian, but I love all the religions. I respect all the religions, everything. I'm an army officer. I've been brought up to respect all the religions. So this is it. So next, modern CPR. As I said, the modern CPR came to existence by June 1962. First DC, defibrillation was given. As I just mentioned, American Heart Association was established somewhere in 1966. So now in 2010, it will be around 50 years. And now 2020, it will be completing around 60 years of this so-called guide. See, 2010, 50th anniversary was celebrated of CPR. The 2020, now it should be 60th anniversary. Sudden expected death. They find a death within 24 hours of symptoms onset in a previously functional individual. Previously alive. He was alive. Suddenly he died. Cardiac arrest. Now your job is to revive him. Accounts for 1/3 of non-traumatic deaths. 1/3 of deaths are because of sudden, unexpected death. And out of that, 75% are attributed to cardiovascular disease and 25% caused by non-cardiac. These 7 cardiac arrests. So now the etiology in adults, usually the result of a cardiac result. Whenever this cardiac arrest takes place, there are broadly in 2 methods. I hope you are understanding. If you want me to explain in Telugu, I can explain. If you want me to explain any other language, I can. So, idea is to get the point home registered in your mind. Mostly broadly of 2, either ventricular fibrillation or ventricular asystole. These are broadly 2 things which causes cardiac arrest. So what you have to do in cardiac ventricular fibrillation causing cardiac arrest is different set of things, and what you have to do when a cardiac arrest takes place because of cardiac asystole, a different set of things which you are supposed to do. Now, result of either primary cardiac disease or diseases which affect other organs. Why are we so bothered about cardiac arrest? Let me tell you, gentlemen, this is not copied from any source on Google or anything available on LinkedIn or anything. Absolutely original stuff. So it will be something out of the blue, taken out of this book. The quality of slides will be at most beautiful and easy to understand. So why are we so bothered about cardiac arrest? 3,30,000 die annually from coronary heart disease. Annually, in each year, 3,30,000. 60% are sudden cardiac. SCA means sudden cardiac arrest. At home, it occurs at home or while en route when they are going somewhere. 80 to 85% in VF means ventricular fibrillation, VT means ventricular tachycardia, which causes arrest. Early resuscitation and prompt defibrillation within 1 to 2 minutes can result more than 60% of survival. I assure you, not only that, even up to 80% survival can occur if you really correctly do resuscitation and prompt defibrillation within 1 to 2 minutes, within 200 minutes. That is very important of cardiac arrest. Which really occurs. We have to be very smart, very quick in action. Then you can say the more the delay, chances of revival goes down. Incidence of cardiac arrest. 70% occurs out of hospital. They are not in hospital when cardiac arrest takes place. CR means cardiorespiratory arrest. 10% of them only survive when it is within the hospital. The survival rate is high. Here needs to 10%, only 15%. I'm sorry. Especially in operation theater, any cardiac arrest takes place. In fact, 10%, 10%, because the patient is already intubated. What you need is a little bit of drugs and a little bit of cardiac arrest. They do survive. Many times it happens. Many times we don't even inform. Patient survives. That's all. It is right. We have to have further observation for long, and we check post-operative also whether any recurrence of things and what caused the thing we investigate. So they do survive much more than 15%. Okay, less than 1/3 get bystander CPR. Like a bystander is standing, person is standing somewhere nearby and cardiac arrest takes place. Only 1/3 of the people, I mean, who die, 1/3 of those dead people receive bystander CPR. Very rarely people come forward to do resuscitation. They're more busy taking videos and other things. Only 10% survival because bystander really try to even attempt CPR. So I would request you as a doctor, don't hesitate. Even if you're standing somewhere, even in a roadside and somebody collapses and you find it to be cardiac arrest, you can try. Okay. Now the COVID problem is there. So I'll tell you what is to be done during COVID era and what is to be done after the era. Hopefully it will disappear very soon. After that, when the COVID problem disappears, how to resuscitate is safe. Even during COVID, suppose your brother or sister is having cardiac arrest, your father is getting cardiac arrest. And as per the latest guidelines, you're supposed to put on a PPE. PPE means all personal protective equipment. Complete care, including the face mask, all the things. Only after that you are supposed to restate. These are interim guidelines. It was tell me. Would you? Are you able to hear? Somebody was asking some question.
Yes, sir.
Okay. Are you able to hear? Okay. I'll give you a chance to ask later questions. Don't put questions right now. It will be just let me first complete the complete thing. Put an complete wrap attention what I'm speaking. Okay. Now, 2000. I'll tell you, you can safely do resuscitation without we can safely do this without being exposed to COVID. I'll tell you how. Okay, now I was telling you what happens. Even professionals, see, even professionals don't know to do good CPR. That is the problem. We are supposed to know doctors, but many people give least importance to this technique of CPR. CPR, अरे वो तो करते हैं, anesthesiologist कहते हैं, let them do. Let's not bother to understand. The anesthesiologist may not be there at the scene. So you should, very, very basic, very simple. Within a class, within one class, I'm going to make you masters. So simple. If you pay attention to just 1 hour, you'll be benefited. To save somebody's life, you play God to somebody, and truly you'll feel proud of yourself being a doctor. You have saved a life. Yes. The problem is that the after people come too slow or too sharp. They don't do properly. That's why people, despite CPR, people die. CPR skills have been shown to decline rapidly after initial achievement of competency. Updates are essential. You're supposed to know what are the latest guidelines. Keep on experimenting, keep on reading about it. Try to question yourself. What is things which are lacking? What I don't know. Those things. Okay. The chain of survival. Immediate recognition of cardiac arrest and activation of EMS. When a person collapses, suppose I suddenly collapse in front of you. Don't start cardiac massage on me immediately without checking. So I might have collapsed. Like recently, one postgraduate student, I won't name the lady, then doing surgery, suddenly she collapsed while doing the surgery, assisting the surgery in the operation theater. I, I didn't administer any CPR or anything. The first thing which is to be thought is check the pulse. You have got a stethoscope, auscultate that the heart is there, respiration, both are there. So it's not a cardiac arrest. So what else it could be? It could be simple vasovagal shock because of standing venous cooling. So they have gone into this thing. And what you have to make her lie down and just raise the foot end. Venous return is better. And the person wakes up immediately. So there is no point a person feels hypoglycemic and falls off. And the heart rate is normal and pulse rate is but perfuse is setting. There's no point cardiac arrest. Let investigate, give glucose, the patient will survive, patient will recover. So there are so many chances of unconscious falling suddenly, and don't jump into CPR. First check the pulse. See respiration, if the respiration is there. Nothing to worry. Cool, fake cool. The patient will definitely come out. Okay? So, well, as I've said, CPR, when the cardiac arrest takes place, I told you either because of asystole or ventricular fibrillation. Now, there you have to play correctly. You don't keep on waiting. You have to act fast. So, that is what I said. The $1,000,000 question is having good common sense. What here? Now, immediate recognition of cardiac arrest and activation of EMS. What is EMS? Emergency Medical Services. Okay. Early CPR with an emphasis on chest compression. Most important is chest compression. Compression. The recent there's a Anesthetic Society of India has completely given importance to. Now what I'm talking is American Heart Association guidelines. The Indian cardiac guidelines has completely IRC, Indian Registration Council. One gentleman called Dr. Chakra Rao, he belongs to this thing, Kakinada. He has done a lot of initiative work and he's getting a lot of accolades for that. So what he said, just don't give mouth to mouth breathing, don't do anything, don't bother about what is that? External cardiac shock, DC shock, and all. Just do external calls. Calls mean compression only, life save. Just by doing correct compression, you can save the patient. 80% will survive. Just giving little compression for around 15-20 minutes, and the patient revives. They come back. That's the beauty of it. Calls only, no need of anything. So I'll tell you about that. Now, early CPR with an emphasis on chest compression. That's most important. Right? A rapid defibrillation. Now, the question is how the defibrillation is to be done. I'll tell you. Effective advanced life support. and integrated post-cardiac arrest here. As I mentioned, patients have revived. Now, what is to be done after cardiac arrest? What is to be done to save them completely? Now, these chains are very important. If you see early recognition, call for help to prevent cardiac arrest, early CPR to buy time, early defibrillation to restart the heart, post-resuscitation care to restore the quality of life. Now, this is early recognition, call for help. If you are abroad, you call 911. But in India, 108. I'm sure you know 108 is the number which immediately ambulance arrives with the necessary help. And till that time, we do cardiac massage, external cardiac massage to prevent cardiac arrest. Next is early CPR, cardiopulmonary resuscitation to buy time. Then early defibrillation to restart the heart. How you do? How much is the shock to be given? And later, post-resuscitation care. Let's show the quality. Now, who's this? Moses. The commandment, 10 commandments. I'm sure you must have watched that famous classic English movie, 10 commandments. Now, what are the commandments of revival? Identify rhythm. Just see in the ECG what is the rhythm if you are in hospital. Know thy equipment. Know thy equipment. You must know your equipment, how to use it. First of all, you should know the defibrillator, how it works and all. You should know it before. Not once the patient is dying, that time you start learning how to defibrillate it. Go and see. Defibrillator is there in every ward, in every place, right in the casualty, right in the OT, operation theater, all important ward, ICU, everywhere. Just spend 5 minutes. It will be written on the how to use it, how to put it, which are the pads, which pad is to be put at the apex of the heart, which part is to be put at the base of the heart, and how much joules of current, Joules. Normally 2 joules per kg body weight you select. But as a rule, now we are for all adults, we are giving 120 to 200 to the biphasic equipment, 220 to 200. Earlier during my time, it used to be monophasic defibrillator. We used to give initially 200 joules current, then subsequently after 5-10 minutes, 300 joules, and subsequently 360 joules. Now the system is the uppermost. Start with the highest and continue every 5 to 10 minutes. Repeat. So that is it. And if the child is very small, 2 joules per kg body weight. Suppose the child is only 10 kgs, you have to give 2 into 10. 20 joules only selected. Don't give 200 joules shock. The child will die. So you have to, again, as I said, play intelligently. The cardiac arrest most important drug to be given IV is epinephrine. That is nothing but adrenaline. The dose of adrenaline is 10 microgram per kg body weight. When you see an ampule of adrenaline, which is epinephrine, you must have seen one ampule of adrenaline. It will be there. That is the most life-saving. If at all, any most important drug so far anybody has created as a pharmaceutical company or in pharmacopoeia is adrenaline. It is the best. So how it looks like? One ampule has only 1 ml. Okay, only 1 ml, and it has got 1 milligram. 1 milligram is 1000 microgram. Just now I mentioned 10 microgram per kg body weight. Suppose I am around 80 plus, but imagine I am actually 50 kg. So how much of adrenaline you are supposed to give IV? That is 50 into, suppose I am 50 kg, 50 into 10. That means 500 micrograms. 500 micrograms means half a milligram. So as I've said just now, in 1 ampule, you have only 1 ml, and that 1 ml is 1 milligram. So give half ml of that as an IV. Now the $1 million question. If you read the ampule carefully, it is written 1 in 1000 concentration. Now, will you give directly? No, you are not supposed to give directly IV. I've been seeing many people give directly IV. In fact, that per se will cause cardiac arrest. dysarrhythmias and the patient will die because of concentrated dose of adrenaline. You have to dilute it to make it 1 in 10,000. Already it is made in 1 in 1,000. Dilute it to 1 in 10,000 by adding normal saline 9 ml. That means 1 ml becomes 10 ml, and 1 in 1,000 becomes 1 in 10,000. And then give 5 ml of 4 to 50 kg person. 5 ml means 500 microgram. Okay, so that is it. Suppose I am 70 kgs, you will give 7 ml. That is the idea. You have to give 7 ml. Yeah, 80 kgs means 8 ml of diluted. One is diluted up to 10 milligram, 10 ml, and made into 1 in 10,000, and you are giving at the rate of 10 microgram per kg. That is the way you are supposed to give. Then the question is, why these manufacturers have made 1 ml and 1 milligram? Are they fools? They should have made it 1 in 10,000 already. Isn't such an emergency drug? Why are they fools to make 1 in 1,000? They're asking you to dilute it when a person is dying. Is it fair? Very important. Yes. Majority of the patients, when you want to give IV, you won't find IV. If a person is already in the hospital, IV is already there, fine, you can easily give intravenous, the drug. But when the patient is dying, when you search for the IV, you won't get the IV so easily. It takes very long time. That time, by the time patient will die. So easy way is just give 1 ml undiluted intramuscular or subcutaneous. Without now, there you don't dilute it with 10 ml of saline, 9 ml of saline to make it 10 ml. You give 1 in 1,000 percentage, 1 ml IM or subcutaneous straight away. It will act. It will act, but later. But it will definitely act in terms of give deep intramuscular. So it will definitely act. Meanwhile, somebody has intubated the patient and giving the ventilation, the other person at the other end will be doing the cardiac massage. So I'll tell you how they work in tandem. Now, universal algorithm. What is this? Cardiac arrest. TLS, basic life support algorithm. Attach ECG monitor, assess rhythm, check pulse. This is the universal algorithm for cardiac arrest. What is it? Assess the rhythm, check pulse. So if you find ventricular fibrillation on ECG or ventricular tachycardia, you follow the VF or VT algorithm. If you find non-VF or non-VT, either asystole, you will follow the asystole algorithm. So the pulse plus electrical activity, TEE. Now there will be some in the ECG. Patient is dying, cardiac arrest has happened. When you try to palpate the pulse, you are not finding the pulse. But when you see the ECG, there will be some electrical activity. That there is no pulse. That is known as pulseless electrical activity. Now you have to know what is to be done in such a situation, either this, or this. Three different things. Main concept. Priority is good CPR. As I said, no half-hearted, no one-fourth-hearted, one-time half-hearted effort. It has to be 100% effort. Good CPR will revive the patient, not half. Do the best possible. I'll tell you what is to be done as best. Insertion of an advanced airway, not a high priority. If you are not able to do endotracheal intubation, don't worry, you can still revive a patient most of the times without giving, without putting the endotracheal tube. Ventilation when possible. As far as possible, try to ventilate with the face mask and press the back. AMBU. I'm sure you know what is AMBU. What is the full form of AMBU bag? Can anybody tell? AMBU. A-M-B-U. AMBU bag. All are sleeping? Hello?
Ambulatory.
No. AMBU bag. You use to put a face mask and press it.
Artificial
one bag.
mask breathing unit.
Artificial?
Mask.
Very close, very close. AMBU. Not mask. Very close,
Artificial
very close. Manual.
Breathing unit. Artificial manual breathing unit.
What's your name? What's your name?
Baby Jan, sir.
What's your name?
Baby Jan, sir.
Excellent. Congratulations. Baby Jan, excellent. You have correctly answered it. Now, AMBU is artificial manual breathing. So we have to know how to use this AMBU bag. And if a pediatric patient is there, the AMBU bag is smaller. Pediatric AMBU bag is smaller. You should know which is to be used, how big is, which is the red end, what is significant, the blue end, what is the white end. White end, red end is to the endotracheal tube. The blue end is towards the back, breathing back. So that is how you press and ventilate the manual compression, manual breathing unit, artificial AMBU bag. Most important is priority is good CPR, insertion of advanced airway, not a high priority, ventilation when possible, avoid excess ventilation. There's no need of hyperventilating, we call HAR. Minimize interruption and chest. Most important is remember continue uninterrupted chest compression. Just even while giving electric shock, that is the only time briefly you interrupt chest compression, but immediately after the DC shock, you revert to your external cardiac massage. That is only will save. The moment you are forgetting to continue cardiac massage, the chances of that is very, very high. Continue cardiac massage. You won't believe, actually, as per the guidelines, 20 minutes you are to the resuscitation. But you won't believe, students, I have seen even after 40 minutes, surprisingly patient has revived, and after 1 week he comes back to celebrate, giving jalebis without knowing what happened. He almost died and we would have left him. That because 20 minutes no revive, but after 40 minutes he survived, and after 1 week he comes back to distribute jalebi. This is life. So you have to put full effort, make a sincere effort to revive. The patient will definitely survive. Okay, basic life support. What is all about? The sequence of procedure form to restore the circulation of oxygenated blood after sudden cardiac. The idea is to send oxygenated blood to the vital organs like heart and the brain. Most important, chest compression and pulmonary ventilation performed by anyone who knows how to do it anywhere, immediately, without any other. This is the most important. Chest compression, most important, and pulmonary ventilation. This can be done by anyone. No need he needs to be a doctor. If you teach your brother who is a non-doctor, if suppose you collapse, he can save you. I can assure you, he or she can save you. That is the idea of calls. Calls we have been teaching even at bus stands, even in a railway station, at airport, just asking everybody to come around, and we used to teach calls. Compression only, life support. Just by teaching them calls correctly, we can save thousands of patients who are suddenly collapsing and dying. So no need of being a doctor. If you know correctly, you can save a life. Who knows how to do it? The anyone, but he knows how to do it. He can save them anywhere. I said, no need to be only in a hospital. You can save a life anywhere in the world. There have been instances, so many people were revived successfully during in flight. I'm sure you have been watching the TV. Such happenings are regular happening. They have been highlighted and applauded very well that after a scene when flying, somebody had a cardiac arrest and resuscitated successfully and happens to be an anesthesiologist. I say no need of being anesthesiologist. Any doctor with basic sense can save a life without any other equipment. You can save. Okay, basic life support. Immediate recognition of cardiac arrest and activation of EMS. Just now I said 108, call EMS, emergency medical service. Goes behind and the airway clears and then breathing. Breathing means if the person is not breathing, you give oxygen or air. No need of oxygen. Without oxygen, just ambubag ventilation is more than enough. In fact, the latest in 2010, the best part that you can ask pediatricians, the newborn resuscitation with oxygen having some problems. They are developing some problems subsequently. Without oxygen, resuscitated child are surviving much more. So the pure air is more than enough to resuscitate. So breathing, you have to resuscitate with normal air. No need of supplementation of oxygen. Even if you do supplementation of oxygen, nothing like that. Do good. But without it also equally effective. C is compression, push hard and push fast. Okay, airway. Tilt the head of this. Can you see? Tilt the head of the person upward. Push hard. You have to put this thing at the center of the victim's chest. Where you have to push this thing compressed at the lower part of the breast uh, blade. That is sternum. 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 The lower one third of the sternum is the place where you have to put your hand, and another hand you have to put interlinked to it. And the active hand is the one on the top. This is the lower. With this, you keep pressing. Don't fall on the person with the good enough so that the heart gets pressed between the vertebral column and the sternum. And whatever blood is inside the heart, it goes into circulation. Idea is to give oxygen blood to the brain, so it doesn't have the brain death. So that is most important. So we have to press it. The airway. I said unless the chin is lifted up, if chin is falling down, niche hai, there is no point. So put the chin up, automatically the air starts going in. And breathing, as I said, you can put endotracheal tube or a face mask or an ambu bag on the face and keep ventilating. You can save the patient. And if you can do mouth to mouth, nothing like it. You can definitely save the patient. Mouth to mouth. And in the child, your mouth will cover mouth as well as nose. So mouth to mouth and nose and ventilate. How you have to do? If you are single, 30 compression and 2 breathing. If you are 2 of you, and children especially, after 15, give a pause and give 2 breaths. 15 is to 2. Otherwise, the this thing is guideline is 30 is to 2. 30 means 30 compression and 2 breathing. Okay, chest compression. If there is no pulse, begin as follows. Now you have found the pulse. Where you have to see the pulse? How you have to do this? Can you see how this person is? This is the way. Cardiac muscle. Lower one third of the sternum. Many people have seen, even doctors keep pressing at the apex of the heart. See here, here they keep pressing rather than lower part of the sternum. You have to put your passive hand and on the lower part of the sternum, one third of the sternum, just below the nipple. So this is one nipple, this is just below it. Even in newborn, the dictum is you place 2 fingers below the nipple line and put 2 fingers and keep on dipping it to 1.5 inches. Keep on doing it 100 per minute. You're doing it. That's how you do. Other way, in fact, I do mostly encircling the hand all around and putting the thumb just at the level of the nipple in the middle. One thumb is at the center of the lower part of the sternum, other thumb at the center. And all the 4 fingers are behind the baby. You know, the whole chest is covered with it. And you keep on pressing. You have complete control of how much is depth and how much you are pressing. So that too much of pressing is also harmful. Now, chest compression. Push hard and push fast. Rate at least 100 per minute. Compression depth is at least 5 centimeters. Allow complete chest recoil. Minimize interruption. Uh, Avoid excessive ventilation, as I've said earlier. Okay. Coming to why compression before ventilation. Chest compression vital in saving them. ABC delays compression. So now we have become CAB. C first, A next B. Rescuers reluctant to open airways and give mouth-to-mouth resuscitation many a time. First few minutes oxygen content is adequate, but delivery is poor. Okay. Passive chest recoil permits air exchange. So when you're pressing the chest, make sure let the chest recoil. That permits the air exchange. Hyperventilation decreases venous rhythm. It's all about blood flow. Emphasis on effective CPR, fast, deep, minimal interruption, single compression to ventilation ratio. I just now mentioned 30:2. Single rescuer, adult, child, infant, excluding newborn. Just now I mentioned about it. And CPR by one rescuer. Can you see? He's doing the same guy was pressing it for 30 times. Then he bends down and gives mouth to mouth breathing 2 times and then comes back to this level and presses for 30 times. That is how you do if you are one person. And CPR by 2 persons. Cardiopulmonary resuscitation by 2 persons. One person is taking care of the circulation, that is the external cardiac massage. The other person is looking after the breathing part. So he is saying the airway and all. He has hyperextended the neck. See, the neck has been extended, mouth is open. That's how he's checking the breathing also. See, he's listening to the breaths. That is how. So, look for the rise and fall of the chest. The moment when you are going mouth to mouth breathing or with the face mask or ambu bag, just giving it for the sake of giving is no point. You see whether the chest is lifted up or not. If the chest is lifting up, fine. Otherwise, the whole thing is escaping to the gap between the mask and the mouth. Listen to the breath sound. Feel for rise and fall of the chest. 2010 American Heart Association guideline has removed this from BLS algorithm. Why? This thing, listen to the breath sounds and all, no? They have removed. Now, at the same time, now 2015 guidelines, they have introduced very interesting. Check for the breathing as well as the pulse at the same time, rather than wasting your time whether the person is breathing or not. Do both the thing at a time. Okay. Early recognition. Unresponsive victims, even if taking occasional gas, are supposed to be dying. If somebody is just taking a little bit of gas, that means you make sure that it's definitely cardiac arrest. Not that he's going to come out of it. You can start the cardiac, you can assume it to be cardiac arrest and needing CPR. Okay, tap the victim. Just ask, are you all right? Are you all right? Okay. If no response, activate EMS and start CPR. Now, head tilt and chin lift. Just now I mentioned head tilt and chin lift. Can you see? Chin is being lifted. Head is extended backward, not flex, extended backward. And chin is being lifted. Chin lift and head lift we have to do because of better breathing. Breathing. What is it? Effective ventilation, mouth to mouth, mouth to nose, mouth to mask, back to mouth. The defibrillation. I was telling you about defibrillation. You know what? How many of you have seen AED? Can anybody answer? AED. What is AED? Can
Automated
anybody answer?
electric defibrillator.
Very close. Automated E,
Electric.
not electric.
External.
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 Correct. Now Bhardwaj has left, and Jeevan Valluru has left. I think they are too intelligent people. Okay? See, I'm talking something so important, and they are leaving. Not very fair. I'm finishing in another few minutes. The most important lecture you can ever, yeah, most important. Now, automatic external defibrillator you will be seeing in all the corridors of an airport. When you travel by air, you just see where the air hostess sits. Just on top of her head, there will be a small mark AED will be written. And once you press, it will open. And there will be a small instrument like thing that is automated external. Why? It's so important. In all important railway stations also they are taking on these days automated external defibrillator because it's so very important. And the beauty of it, you don't have to be doctor to apply it. You just have to follow what is written on the AED and do the things. Once you open it, there will be one switch to put it on. Just press the button, put it. Are you listening? Everyone, are you listening?
Yes,
Hello?
sir.
Only
Yes,
one
sir.
voice. What about others? Are you listening? I'm telling something about very, very important automated external defibrillator. Are you listening? Anybody around? Any other voice?
Yes, sir.
Yes. Okay. I'm really sure that yes, somebody is listening. So this is very important. I'm telling about automated external defibrillator. It is so very easy to save a life by giving defibrillation. This is readily available in most of the places. But you should know how to use it. Now, there is no need to be a doctor. Just common sense can. Once you open the equipment, there'll be a red button. You press the button, it will put on. It will on. Now, next, open the box. There'll be two pads. On the pad itself, there'll be a diagram. You know, where that pad is to be placed. Is it at the apex of the heart or just below the right clavicle? It will be written. It will be showing, the diagram will showing. There you paste it, both. And they will have cords. And that cords end in a plug. You dip that plug into the equipment. Now the electric will start flowing into the heart. Then leave the patient slightly away. Because now the electric current will start moving and it will be start analyzing the heart. So at that time, don't touch it, because by your touch, the wrong interpretation may happen. So leave the patient. Once the interpretation takes place, it itself tells you that it needs, it's a ventricular fibrillation, you need to give shock. Okay, you need to give shock, and you don't have to worry how much is to be given. Everything it itself knows how much is to be given. The itself it will be loaded, but it will not give the shock of its own. You have to press a button. It will tell you, please press the button, please press the button of shock. Then you have to press the button. When you press the button, the shock will be delivered. So the ventricular fibrillation or ventricular tachycardia or atrial fibrillation or supraventricular tachycardia, all these things will be corrected in minutes with this one DC shock which you have given. Okay, the best part of it, if the AED senses that it is not a ventricular fibrillation, it will not load itself. It will not give you a shock. It will give you, it will tell you that continue external compression. So you will start continuing your external cardiac massage, which is most important. So that is it. So that's so simple. So next time when such thing happens when you're flying, somebody please attach this AED and save it. Okay, so simple. You have saved a life, but once you know the usage of that AED, then only you can use it. Now in the hospital, you know, we have monophasic. If you are old hospital like government hospital, and they are monophasic defibrillator where you have to give 360 joules. But the latest in our hospitals, all the defibrillators will be latest thing. They are biphasic, and you have to give only 200 joules, 120 to 200 joules at one go. Just you have to put one pad at the apex, one pad at the just below the right clavicle. It will be written where it has to be put, and press the button simultaneously. The current will be delivered. When the current is being given, vacate the patient, because you will be electrocuted. So leave the thing, and then you continue the cardiac massage. So this may not end in one. You see any improvement in ECG or anything, any respiration has come or cardiac pulse has come. If it has not come, every 5 to 10 minutes you can repeat the shot. Meanwhile, you keep on continuing still cardiac massage along with certain drugs which I am going to mention. Okay. Out of the hospital cardiac arrest, shock within 5 minutes of receiving call EMS, public access. Just now I said PAD. AED is nothing but that. In hospital, first healthcare responders should use defibrillator immediately, effective mainly in ventricular tachycardia and ventricular fibrillation. That is helpful only in these two. The recommendation of optimal energy in the initial shock is 150 to 200 joules for a biphasic waveform defibrillator and 360 joules when you are in a monophasic biphasic. Okay. Major changes. Importance of good quality is push hard, push fast, avoid interruption, don't hyperventilate, defibrillation. First call for defibrillator, then do CPR, deliver 5 cycles of 30:2. Okay, 30:2 CPR within 2 minutes, and then go for help or telephone. Return to the patient, resume CPR, airway management. Now, advanced life support. This is so far we have discussed about basic life. Now the advanced life support is nothing but giving some drugs as well as giving DC shock. Besides cardiac massage and mouth-to-mouth. Now what are these? Respiratory proficiency, no training, highly trained, multi-rescuer, coordinated CPR, 30:2 CPR, hands-only CPR, building blocks of CPR, chest compression, rescue breath, keep up. To self-explanatory. Advanced cardiac arrest. Intervention to prevent cardiac arrest, treat cardiac arrest, improve outcomes of patients. And ROSC. What is ROSC? Can anybody tell? ROSC. The cursor is showing. Can anybody tell, please, what is ROSC? Not the same voice who's been telling. Maybe. No. Somebody else. Can anybody answer? Is anybody around, first of all? What is ROSC? Return of spontaneous circulation after 5 minutes. Okay. This is advanced cardiac arrest. Harish Rasala has left. Congratulations. You have become master in advanced cardiac arrest. Fine. Okay. Advanced cardiac arrest intervention built on strong BLS foundation. Immediate recognition, activation of the emergency response system, early CPR, rapid defibrillation. Advanced cardiac arrest, just now I mentioned return of spontaneous circulation. This is ROSC. That means when you are doing good CPR, there will be return of spontaneous circulation. That means patient is revived. Drug therapy. What is the drug to be given? Advanced airway management, that is endotracheal intubation. Physiologic monitoring. Following ROSC, survival and neurologic outcome can be improved with integrated post-cardiac arrest care. After ROSC, you have to do this. 2010 adult ACLS guideline, adjunct of airway control, ventilation, management of cardiac arrest. Now, don't worry that I'm stuck at 2010. I'll come to 2015, then 2015 and 2020, minor changes from 2010. If you know 2010, you know everything. Very, very minute changes in 2015 and 2020. Okay. Now, adjuncts of airway control and management of cardiac arrest, management of symptomatic brady and tachycardia. Bag mask ventilation. Just now I mentioned ambu bag is nothing but ventilation. And if you are in the OT, you have seen how we do cardiac massage as well as bag mask ventilation. We have different type of face mask. No recommended, not recommended for a lone provider. When you are alone, don't try bag mask ventilation. Try to do only cardiac massage. Don't provide mouth to mouth mask can be done. But 30:2, as I said, keep on doing cardiac massage and give a pause and give 2 breaths and then continue 30 cardiac massage. Bag mask ventilation is most suitable when performed by 2 trained providers. One opens the airway, sees the mask to the face, other squeezes the bag. This is safe. Can you see? This is the face mask. How nice. This is ambu bag. This is the same. Airway adjunct, cricoid pressure, impedes. Many people say cricoid pressure to be put. Cricoid pressures help to avoid aspiration. Suppose that aspiration takes place, the whole his food particle goes into his airway and any chance of survival goes off. But many times cricoid pressure, if you are putting too hard, it impedes ventilation, interferes in the placement of supraglottic airway. Supraglottic airway is nothing but LMA. Huh? Take a laryngeal mask airway or intubation. Endotracheal intubation, it interferes if you press cricoid much. Routine use of cricoid pressure in cardiac arrest not recommended. Where is cricoid? I hope you know where is cricoid. Just below the thyroid cartilage. Advanced airways, laryngeal mask airway, combi tube. I hope you have seen combi tube. Combi tube is nothing when you are not able to endotracheal tube. Just push it inside. That's all. It will go anywhere, but you'll be able to ventilate. Inflate both the both the valves, both, and start ventilating, and you'll be able to ventilate if you have combi tube. Endotracheal tube, you have to put in the trachea through the glottis, through the vocal cord. The laryngeal mask airway. These are various sizes are there. Combi tube, just now I mentioned combi tube. This is the combi tube. Just push it inside and inflate both the cuffs and start ventilating. You see, if the air is entering the lungs with putting the ambu bag here, air is fine. If it is not going, put the ambu bag in with this and you start ventilating. Then auscultate. If the air is going, that means you are in the right place. You keep on ventilating. It has to go. This is slightly bigger. This pharyngeal thing, you have to increase to the around 30 ml of air you have to inflate the cup. The idea is to completely block the pharynx so that any regurgitation doesn't go into the thing. And this blocks the, if you inflate, no, this one, it blocks the esophagus, so nothing goes behind. So nothing will go into the trachea. But at the same time, if you see, you must have seen these are the holes. With this holes, no, it will go. The whatever you are ventilating, it will, because it is blocked, it won't go into the esophagus. It has to go into trachea only. So ventilation is as good as putting a endotracheal tube. So when you are not, you don't know how to do endotracheal intubation, use combi tube, just push it and put a combi tube. Laryngeal tube is similar, almost on the same line. Laryngeal tube is almost on the same line. Just now, endotracheal tube, you must have seen 100 times endotracheal tube. This is marked in centimeters. When an adult, we use, see, this is the mark, you know, it has to go inside. This tip should be at least 4 centimeters above the carina, or this tip should be at least 1.5 inches after the vocal cords are passed. Okay, so then inflate the cup. And normally the easy way from at the inside tooth, no, what we say, if the mark is up to 20 in the females, we put the depth, and the males we put up to the marking of 22 to 24. This is the depth. This perfect intubation, and you auscultate the lungs both sides. If air entry is there, that means they're perfectly ventilated. Don't push it up to the carina. Where is carina? It is close to T4 vertebra, T4 thoracic 4 vertebra, carina. Carina is the part where the bifurcation of the trachea takes place in the left. The above the carina by around 4 centimeters. Just now I mentioned. Okay. Now, clinical assessment. Thorough assessment of enterotracheal position immediately after placement. When in doubt, use laryngoscope to visualize whether the tube has passed through the vocal cords or not. If still in doubt, remove the tube. When you think that the tube has not gone into the thing, remove the tube and put the face mask and keep ventilating. You'll save the patient. See, this is the, once you intubate correctly, you will see around 40. Okay, and if you are not intubated correctly, if it has gone into the this, if it is capnograph is not there, but this color change, if you have intubated correctly, there will be color change. No CO present, this will be the color. If the CO is CO2 is, this is the color. With that, you know whether you have put the endotracheal tube correctly in the trachea or not. Management of cardiac arrest. Cardiac arrest can be caused by 4 rhythms. I told you: ventricular fibrillation, pulseless ventricular tachycardia, pulseless electrical activity, or assist. Now, this is the logarithm algorithm. Sorry, it is an algorithm for shout for help, activate emergency response, start CPR, give oxygen, attach monitor, defibrillator, rhythm, shock. Is it shockable or not? See, that means ventricular fibrillation, give VF. If it is VF or VT, give a shock. CPR 2 minutes, IV or intravenous access. See, if you are not able to give IV, you can give intraosseous also on the upper part of the tibia. Okay, the drugs can be given intraosseous also. And sometimes when nothing is, IV is not getting, you are not able to give intraosseous and intubate it correctly, you can put all those drugs into the endotracheal tube also. It will reach. It will be absorbed through the lungs. So that is how you save the patient. You have to save. The criteria is to save the patient. Okay, rhythm shockable, CPR 2 minutes. Epinephrine, just now mentioned, adrenaline has to be given every 3 to 5 minutes. Consider advanced airway. See the capnography, rhythm shockable. Again, if it is yes, shockable, again give a shock, CPR again 2 minutes. Now give. This is the most important drug, amiodarone. This is the anti-arrhythmic drug. When the shock you are giving repeatedly and it is not reverted to sinus rhythm, just give this valuable drug. It is readily available in all the hospitals. I've checked. The first thing we check is when I come to ashram whether amiodarone is there or not. It's very much available. Give amiodarone 300 milligram IV. Don't give immediately. It has to be given slowly over a period of 10 minutes, and 300 milligram first bolus dose, and after amiodarone, it can be repeated after 5-10 minutes if nothing is happening to 150 milligram. Okay, you can keep on repeating up to 1 gram per day in 24 hours. And best part is I have saved a life in Medicity where I was working in Medicity, Hyderabad. We gave external this thing, this shock. We gave epinephrine, whatnot, everything. Patient is not recovering. We gave amiodarone and gave a shock. The patient was successfully resuscitation and survived. So, and this is the importance of amiodarone. Just don't forget amiodarone. Tardarone, this thing, it's readily available with the name Tardarone, but the pharmacological name is amiodarone. Now, if the patient is dying because of asystole, this is the line graph. This is the algorithm for the ventricular fibrillation ventricular. This is the graph for asystole. I told you it is basically cardiac arrest takes place either because of asystole or ventricular fibrillation ventricular. With the ventricular fibrillation, there is no role of electric shock in asystole. Just only one thing most important, CPR, only cardiac massage. And the drugs, as I said, keep doing cardiac massage and give the drugs epinephrine every 3 to 5 minutes. Repeat. Consider advanced airway if it is possible. Put an endotracheal tube. Keep ventilating. If you are not able to do, push a combi tube. You can do it. Or if you are still not able to, put a face mask and keep ventilating it. Okay, CPR 2 minutes. Time. Okay, I'll finish in 5-10 minutes. That's 5-10 minutes. I'll finish. Okay. This is important. Push hard and minimize interruption. ROC, return of the spontaneous circulation has come. I have told you already about this. Drug therapy, I have already told you about. Vasopressin earlier we used to give 40 units after first or second dose of epinephrine. Now this has been removed in 2015. Amiodarone is still continuing. As I said, first dose 300 milligrams, second dose 150. Advanced airway supraglottic, advanced. This is nothing but LMA, laryngeal mask airway. Waveform capnography, I just now told you. 8 to 10 breaths per minute, you have to continuously chest. 8 to 10 breaths per minute, you have to give. That means 5 minutes, in 60 seconds, you have to give 10 breaths. That means every 6 seconds, keep on giving 1 breath. No need of synchronizing at random. One person keep on cardiac massage, one person keep on giving 1 breath every 6 seconds. Okay, when you are having 2 persons. Otherwise, when you are alone, you have to do 30 cardiac massage and 2 breaths. When you are 2 person, 1 person will continuously give ventilation every 6 seconds, 1 breath, and 1 person will keep on cardiac massage. This is the same thing almost which I have shown you. Now, what are the reversible causes which causes cardiac arrest? Either hypovolemia, 5H, hypovolemia, hypoxia, hydrogen ion acidosis, or hypo or hyperkalemia, hypothermia. Tension pneumothorax, tamponade, cardiac toxin, thrombosis, pulmonary thrombosis. Now, monitoring doing mechanical parameters, not important. This is the intraosseous. This is the drilling machine. Intraosseous. We are not able to start IV, so you are putting all the drugs into the upper part of the tibia. Okay. Drugs. Sometimes the patient is not reviving because of giving too much of opioid. So you have to give naloxone that time. Earlier we used to give atropine. Now we are not giving atropine. Earlier we used to give vasopressin. Now vasopressin has been removed. Amiodarone we are still continuing. Lidocaine we are giving. Epinephrine we are giving. Endotracheal drug delivery. As I said, when you are not able to start IV line, you can give drugs in the endotracheal tube also. Interventions not recommended. Now, I told you atropine earlier we used to give. No, now we are not giving atropine during resuscitation. We are not giving calcium. We are not giving precordial thumb also. During my time, most important method used to resuscitate was precordial thumb, because the sodium bicarbonate, for all acids we give sodium, now we are not giving sodium bicarbonate. Precordial thumb, I'll tell you, very, very interesting. When there is cardiac ventricular fibrillation, one precordial thumb, tuck, one slap on the cardiac, it can convert into sinus rhythm. But the biggest problem is that, God forbid, it is not ventricular tachycardia, ventricular fibrillation. It per se, this precordial thumb can cause ventricular fibrillation, the patient can die. So that's why probably they have removed the precordial thumb. But I have done many, many precordial thumb and patients survive. Post cardiac arrest treatment and all. Thank you. But now, which is the most $1 million question, what is the difference between 2010 and 2015 guidelines? Very, very minor difference. Earlier, compression rate used to be 100 per minute. Now, the compression rate is 100 to 120 per minute. Earlier, we used to give 2010 vasopressin after adrenaline. Now, we are not giving vasopressin. Okay. Now, organ donation importance has been tremendously improved in the latest 2015. More emphasis is given organ donation. Earlier we never used to give. Now we are giving more emphasis extracorporeal circulation. This is employed early in 2015. Earlier we never used to do that. No, not that. Now earlier activation of EMS, what we used to do immediately after seeing the patient not responding, we used to call for 108. Now it's flexible. First, they say that first you do cardiac massage and try to resuscitate for some time, then you make a phone call or something. Don't waste time in making a phone call and waste precious time. Now, the $1 million question, now 2020 has come. What is to be done? Can anybody dare to resuscitate a patient when you're not even going near a patient for fear of contracting the disease? That is most dangerous SARS, serious this thing, respiratory syndrome. You can SARS is full form as serious acute respiratory syndrome, COVID-2. You can contract it by going near to the patient and trying to resuscitate yourself. So how do you do it? Now they have in 2020, same AHA, American Heart Association, has given one guideline which is known as interim CPR guideline, that is valid only as long as the pandemic is there. After the pandemic, we will revert back to what we have been doing in 2010 and what we have been doing in 2015 guidelines. Everything which I have told is the golden standard, but not in COVID. COVID, you must wear PPE, that is protective equipment gear, you must wear. And as far as possible, when you are using bag mask ventilation, you should have tight seal with HEPA filter. What is HEPA? High efficiency particulate air filter. You must have it. Okay. And use video laryngoscopy. As far as possible, use video laryngoscopy. That's very essential, because in first attempt also itself you'll be able to intubate. So this is basically the same. Nothing much has changed and is not going to change. I hope you have enjoyed the lecture. I have already surpassed the limited time. Thanks for the patient listening. Are you still there? Say yes or no. Hello, is anybody
Sir.
still there?
Yes, sir.
Have you liked the lecture? You like the lecture?
Yes, sir. We liked
Thank you
it.
so much. Thank you for patient listening. And please, if those people who are not attending the lecture, please tell them what I have taught you today. I'm sure that you have understood every word which I've said. Thank you so much for patient listening. Goodbye, all the best, and happy saving lives. Thank you. Babu, ఎక్కడ ఉన్నావు? Babu? Babu? ఇది సేఫ్లీ రిమూవ్ రికార్డ్